All right, next up is the W in Learn to Swim. This is for Wilms tumor. Wilms tumor is going to occur in infants up to about 6 years. You can see this really, really rarely in teenagers, but it's going to be the most common renal tumor in an age range that's about right around 5 years old. I'll show you that in a second. A lot of the times you're going to recognize this histologically because it's triphasic. It's going to have blastema and epithelium and stroma, and you're going to know right away it's the Wilms tumor. You can see blastemal predominant variants, but in a lot of tumors you can also see glomeruloid bodies, which is a really good clue. Even if you don't see epithelial elements, glomeruloid bodies are kind of an epithelial element themselves. So if you don't see tubules, but that's going to be a really good clue to what this is histologically. And of course, the fact that it's arising in the kidney of a kid under 6 is going to be very, very helpful in putting that high on your differential. So desmoplastic small round cell tumor can be in the differential, particularly because of some overlapping immunohistochemical features. Both these tumors are going to be positive for desmin and keratin. Now, not often do we do immunohistochemical stains on Wilms tumor because, like I said, that H&E pattern is going to be very characteristic. These are not going to have any EWSR1 rearrangements. That's going to help you distinguish it from some of the histologic minutes, particularly desmoplastic small round cell tumor in an older kid. And if you're ever getting quizzed about this, it's good to know that Wilms tumor is associated with syndromes like Weger and Beckwith-Wiedemann. So here's the age range. Remember, I said earlier that age and location are really helpful. If you have a renal tumor in a child, this is how the age is going to help guide your thinking. If you're looking at a congenital tumor, an infant, somebody under 1 year of age, you'll see that Wilms tumor is on the list, but it's second. It's more likely before the pre-biopsy, pre-test probability. Most likely that's congenital mesoblasthic nephroma. It could be rhabdoid tumor. That's up there, but those are less common. From about 1 year old to about 6, Wilms tumor is the most common tumor, and then other things are far behind it. So here's an imaging study. This is a cross-section of a coronal section of a patient who has been identified as having an abdominal mass. And I show this because it has something very characteristic where you can see the kidney is kind of wrapped itself around the tumor, and that kind of wrapping itself around the tumor is called a claw sign by radiologists. So this is evidence by radiology that this is a primary renal tumor. And here's that same tumor cut in a similar plane. You can see the tumor is kind of surrounded by normal kidney. It's kind of growing into the hilum. Histologically, so here's an example that's pretty poorly differentiated, and all you really see are those blue cells. And at higher power, they're not exactly all round. Some of them are more elongated. I think in a lot of examples of Wilms tumor that I've seen, when it's well fixed, the blastema tends to do this kind of mosaic tiling where the nuclei respect each other, they don't overlap each other, but it kind of looks like a mosaic tile. It's not really well represented in this picture, but that's something to look for in the blastema. Now here's a really nice example with an epithelial element blastema and this less cellular stroma. This is the only picture you need to identify that this tumor is Wilms tumor. So the picture like this, fair game to ask you what is the diagnosis and what syndrome might the patient have. And here's a glomeruloid body. So a lot of tumors in kids, these primitive tumors, they're primitive cells that are trying their hardest, not very well, but they're trying to recapitulate normal growth and development of whatever they should have been. And this is an example of how cells in Wilms tumor can try to make something that looks like a glomerulus. So you have this very primitive structure, very primitive cells, and it's kind of trying to make some like vascular spaces. It's doing its best to try and make a glomerulus. It's trying to tell you that this is a Wilms tumor because it has evidence, histologic evidence right here of renal differentiation. Here's another example where you have stroma, you have blastema, you have epithelium, and you have an even less well-differentiated glomerulus. If you look at fetal autopsy material ever, you might see some things that look pretty close to this in a young preterm fetus. The other thing to know about Wilms tumor is anaplasia. So the definition of anaplasia in Wilms tumor is that you want to have cells that are at least 3 times enlarged compared to the average size of the tumor's cells, and they're going to have hyperchromatic chromatin. And you have to have these hyperchromatic large nuclei and multipolar mitoses like this little stick man right here. You have to have both of these things to call something anaplasia. in Wilms tumor. And if you have it just in one area on one slide, that could be considered focal, but if it's a couple of separated sections, or if it's throughout the tumor, that's going to be considered diffuse. That's going to be associated with worse prognosis. It's really important that you carefully map where you take your sections in a Wilms tumor section so you can identify where this anaplasia is and if there's two slides of it, if they're right next to each other or not. Now, the other thing to know about anaplasia is occasionally, not really commonly, but occasionally we'll just get a biopsy. So if you just get a limited biopsy and you see anaplasia, you actually have to call that diffuse because it's assumed that if it's assumed that if you find it in a limited sampling, it must be throughout the tumor. All right, so here's the highlights for Wilms tumor. It's going to occur in kids under 6. That triphasic histology is incredibly characteristic and very helpful when you can see it. The WT1 protein, and I say both ends, I mean the amino-terminus and the carboxy-terminus. Unfortunately, now there's only one of those commercially available, the C-terminus, but that's going to be positive, and you're not going to have a rearrangement for EWSR1. Desmond and keratin are going to be variable and know the associations with things like Weger and Beth-Guttman.